Hello, and welcome to our sixth module of our educational program, and this is by myself, Samantha Dittmer, and Brittany Hartman.
I discussed infant and child hunger cues. I went over hunger signs for babies and toddlers. A baby will put their hand to their mouth or become more active and alert, and toddlers reach or point to food and get excited at the sight of food. I also went over signs that a baby and toddler is full. Fullness signs included a baby relaxing their body and opening their fists and turning their head away from the bottle and nipple, and a toddler pushes food away or closes their mouth when offered food. I further went into describing responsive feeding. Responsive feeding is recognizing and responding to child cues of hunger to support and maintain the child's innate capacity to self-regulate energy intake and avoid overfeeding. I went over many strategies for responsive feeding. One example is accepting food refusal, as you don't want to override your child's own internal hunger and fullness cues. You can always feed them next meal if they did not eat.
So we'll go over first a little review from our last session. So in Module 5, I went over birth trauma and PTSD, and we learned that 1/3 of all women describe their birth as a traumatic experience. We also learned that trauma is based on the perception of the event, not just the event itself. So two people might experience the exact same event, but one may perceive the event as traumatic and the other may not. And we also learned that PTSD can occur due to a traumatic event. That may be during pregnancy and childbirth, or it might come as a flashback from PTSD experienced before childbirth.
So today, my topic is infant and child feeding problems and solutions. By the end of my presentation, parents will be able to define a feeding problem, identify conditions that are associated with feeding difficulties, list types of eating problems, understand the importance of addressing eating problems, identify eating problems and set goals if it applies to you and your child, and explore solutions and interventions. So what is a feeding problem? A feeding problem is identified when a child is not progressing through the typical course of steps to independent feeding of table foods. Some children have difficulty with efficient, satisfying feeding experiences beginning at birth. Others stall or struggle to move forward in accepting a variety of tastes and textures, and occasionally children will show a regression or sudden change in their feeding skills. That causes and associations of feeding issues in infancy and early childhood are widely varied, and almost all feeding problems depend on multiple factors. Before I move on with the presentation, I wanted to show a quick video that discusses pediatric feeding difficulties from parents' perspectives. You can stop watching the video at 2 minutes and 30 seconds. So how you can conquer feeding struggles with occupational therapy. Parents need help to maintain a positive and healthy relationship with their child and to help their child conquer feeding difficulties. It's important to address pediatric feeding struggles to nourish the healthy development of your child. When infants and children struggle to eat, it's complex. OT can help in so many ways. If your child has been diagnosed with a condition associated with feeding difficulties, occupational therapy can look at ways to overcome these difficulties. Or they may notice that something is off and refer you to the right doctor or medical professional for a consultation. OT can also help you identify a feeding problem. Occupational therapy can help set parent and child specific goals that are attainable for your child to succeed. And OT can further provide services and help problem solve these difficulties with interventions. So a majority of infants with more severe feeding disorders have medical and/or developmental conditions that predispose them to or are associated with difficulties feeding, as outlined on this slide. These conditions include structural abnormalities of the face, oral cavity, or aerodigestive system. An example of this would be cleft lip or palate. They may also have neuromuscular and developmental disorders, such as cerebral palsy or a generalized hypotonia, meaning they have poor muscle tone. Your child could also have cardiorespiratory disorders like congenital heart disease. They could also have GI disorders, so gastroesophageal reflux disease, known as GERD, food allergies, and constipation. In most cases, the medical conditions that predispose infants and young children to having difficulties feeding interfere with the child's ability to perform the activities of feeding as a result of neuromuscular dysfunction in coordination, inadequate strength and/or rapid fatigue or lack of endurance, an inability to coordinate suck, swallow, breathe normally as a result of respiratory distress, and/or nausea and discomfort during the feeding process. There are a number of eating problems that have been identified among children with special needs. One common one is food selectivity. Child can have selectivity by the type of food. So an example of this is only eating bacon, an occasional grape, and drinking formula, and refusing all other foods and drinks. They may also have selectivity by color. So the toddler may only want to eat beige or light brown foods, such as dry cereal, French fries, and chicken nuggets. There may be selectivity by brand. So a toddler may eat only certain brands of food and refuse to eat if the packaging displayed the brand was not visible. So for example, if the Cheerios or Life cereal boxes were not on the table, she would not eat the food. There's also selectivity by texture. So a toddler only eating approximately 50 ounces of pudding, yogurt, and baby food per day, and refusing all other foods and drink. Other children with selectivity by texture may eat only dry, crisp foods such as cereal or avoid mixed textures such as stew. And there's also selectivity by appearance. So a 3-year-old boy would refuse to eat a food item if it had a burnt spot, discolored area, or any type of blemish. Other types of feeding problems are listed on this slide. One is a chewing skill deficit. So the child never learned to chew, and as a result, he ate only oatmeal pudding and yogurt is an example of this. Another eating problem is excessive fluid intake. So maybe a girl drinking up to 90 ounces of fluids per day and eating minimal amounts of solid food. Other children may drink only high-calorie formula and eat little to no solid foods. Another eating problem is adipsia. So only eating solid foods and refusing all liquids, regardless of how they were presented. Another eating problem is insistence on eating only with certain utensils or dishes, so eating only from a specific bowl or using a specific spoon. Another eating problem is refusal to sit at the table, so your child refusing to sit at the table for meals and only wanting to eat while walking around the house or watching television. Another eating problem is food refusal. So your child only eating progressively smaller variety and volumes of food until they require a gastrostomy tube surgically inserted. Another eating problem is refusal to self-feed. So refusing to hold utensils, drink from a cup, or pick up food with their hands. Another eating problem is refusal to eat in public places, so only wanting to eat at home, maybe alone in the kitchen or living room, and refusing to eat even the preferred foods at school or in other public places. So there are several good reasons for starting to resolve your child's feeding problems and addressing these eating problems. One reason is to ensure that he or she will eat a nutritionally balanced diet. A well-balanced diet is important to a child's long-term physical health, and healthy children present fewer behavioral problems. Another reason is to make the family's life easier, because there are numerous social benefits to improving a child's eating behavior. For example, parents often report that two important mealtime goals are to be able to prepare a single meal for the entire family or to eat it without the child displaying the highly disruptive behavior that has accompanied previous meals. So improving a child's eating also allows a family to begin dining in public, which formerly may have been impossible. Another reason is to stress that meal and snack times are important times for socialization. Children who do not eat with their families or peers can miss opportunities to develop social skills and friendships. This also promotes other skills by improving eating skills. The development of eating and speech are correlated because the muscles used for drinking, chewing, and swallowing are the same muscles that are used for talking. So the fine motor skills used for self-feeding are the same skills that are used for a variety of other academic and self-help skills as well. And then you also want to decrease other unwanted behaviors. So for many children with autism, eating problems involve an array of ritualistic behaviors, such as eating only specific foods or using specific utensils. So treating their eating problems may decrease their insistence on sameness and rigidity, not only with eating, but with other environments as well. There are many potential benefits to addressing eating problems. Doing so requires the commitment of time, effort, and resources. Thus, you will need to determine when and whether you can make these commitments. Initially, the time required to develop and implement a feeding intervention may be greater than the time you are currently spending feeding or preparing food for your child. This is a common occurrence whenever parents conduct a systematic program, because it takes time for your child to learn new ways and to develop skills to eat properly. However, once you've taught your child to eat new foods, you will be delighted by the time that you have gained, and this newfound time can be used for other skill development programs or to simply just enjoy some stress-free leisure time. So the first step in developing an intervention for your child's eating problems is to identify them. Ask yourself these questions. What do I consider to be an eating problem? What is my child doing or not doing with his or her eating that I and the family would like to change? And what changes would improve both my child's eating and our family's life? As you evaluate your child's eating problems, think about why his or her current eating pattern exists. What is happening to prevent your child from progressing toward eating a more balanced diet or helping the family attain a more typical way of eating meals? You want to identify not only what you wish for your child and what you wish they would do differently, but also what you can change to improve meal times. So we see many parents who work hard to overcome their children's eating problems, but make little progress. In some cases, their desperate attempts to help are counterproductive, and they may maintain or even exacerbate the eating problem. For example, we commonly see children with extreme food selectivity, whose parents have resorted to giving only preferred foods because the child refuses other foods. Although the child eats the preferred foods, his or her selectivity is reinforced because he or she never has the opportunity to try new foods. To avoid prolonging such situations, it is important to examine what your child and others are doing at mealtime. You can evaluate your child's eating problems by asking yourself and other family members some of the following questions. The purpose of these questions is to help you identify possible eating problems and discover information to use in developing an intervention. So the first question is, what foods does your child currently eat? Many children with special needs have problems with food variety. Most eat a narrow range of foods, and some eat only certain textures, brands, or temperatures of food before addressing variety. It is important to know which foods your child is eating. Identifying the types of foods your child is eating will help determine the quality of his or her diet, as well as any actual or potential deficiencies in vitamins and minerals. There are many methods used for evaluating a child's diet. Two of the simpler and most common ways are food diaries and inventories. A food diary is the easiest way to evaluate a diet. You select a 3-day period in which you will record all of the foods and liquids your child consumes. You can use this food diary to discuss your child's diet with your pediatrician and compare the food diary to a nutrition guide for the children so that you can have a frame of reference. There are many guides on children's nutrition. Another way to evaluate your child's diet is to complete a food inventory that contains a lengthy list of foods from each food group. A food inventory provides an easy method of evaluating the variety in your child's diet. It differs from a food diary in that the foods eaten by everyone in the family are recorded, as opposed to just the foods that your child is eaten with eating problems. The next question is, how closely does your child's diet match the family's diet? The food inventory will tell you just how closely your child's diet matches that of the rest of the family. If your child has eating problems, it is likely that he or she and the family have different diets. Thus, although having your child eat a wider variety of foods is your goal, a wonderful side effect, once it is achieved, is that your life will be easier because you will be spending less or no time preparing separate meals. As a result, more time will be available for quality teaching or leisure activities. The next question, how much is your child eating? It is important to know not only what your child is eating, but also how much. When a child is eating only a few foods, it is easy to assume that his or her caloric intake is inadequate. It is not uncommon for parents to assume that food selectivity and caloric intake are related and believe that a child who displays food selectivity will not meet his or her daily caloric needs. This parental concern can occur even when the child's weight and height are in proper proportion according to standard growth charts. In fact, many children eat narrow diets but do not have problems with their physical growth. In some cases, this is because they drink large quantities of milk or formula. This is why it is important to discuss your child's growth with your pediatrician prior to beginning an eating intervention. The next question, what is your child's meal or snack schedule? Determine what is eaten and when it is eaten. It is important. Some children who eat a large amount of snack foods throughout the day eat little nutritious food at mealtimes. Other children refuse what is offered at mealtimes, then later request their preferred foods because they are hungry. What and how much is your child drinking throughout the day? It is not uncommon for parents and children with eating problems to report that their school-age children are drinking from 40 to 90 ounces per day and eating little to no solid foods. Although fluid intake is important for adequate hydration, it is important to examine what types of fluids are being consumed. In some cases, children who drink large quantities of milk, fortified milk, or high-calorie formula are simply not hungry enough to desire solid foods. Where does your child eat? In some cases, children refuse to sit at the table with the family for meals. Instead, they eat while standing at the table, walking around the house, or watching television or videos. Your intervention will concentrate on eliminating these problems by teaching your child to sit at the table. Thus, you develop your mealtime intervention. You will need to decide if you want your child to sit in a chair, a booster seat, or high chair. The choice, of course, will depend on in part the child's size and what he or she prefers to sit on. Next question, how is the food presented? Some parents worry about pushing or introducing their child to eat, and thus they allow him or her to determine what food is presented at meals. As a result, the range of foods offered at meal times can be limited. In other cases, parents prepare a separate meal for the child to eat, either with the family or alone. In other cases, parents prepare a separate meal for their child after he or she has refused the family meal. How does your child react to new foods? Children vary widely in terms of how they react to new foods. Some will taste or lick new foods, others will allow new foods to be placed on their plates. Although they will not try them, some will not allow new foods on their plates. The worst situation is when children gag and vomit at the sight or smell of new foods. Does your child insist on specific dishes or utensils? Some children are resistant to any change at mealtime. This means that they may react to a new utensil or dish in the same negative way they react to a new food or eating location. Other children are not bothered by any mealtime changes other than food-related changes. How long is a typical meal? Most family meals last 20 to 30 minutes. However, the length of meal times can vary widely for families of children with eating problems. Some children spend less than 5 minutes consuming a meal, and parents' attempts to keep them at the table longer produce conflict. Other parents have the opposite problem, wherein they spend well over an hour just trying to get their child to eat a small amount of food. As you consider the length of meals, think about how much time your child spends eating and how much time he or she spends engaged in other activities at the table. The last question, does your child become upset and display problem behaviors at mealtimes? Before implementing an intervention, it's important to gather information about what problem behaviors occur, when they occur, and possible reasons to explain their occurrence. Children cry, throw tantrums, throw food, exhibit other types of mealtime behaviors for a variety of reasons. For example, if your child throws a tantrum when he or she is asked to come to the table for a meal, the tantrum could be an attempt to avoid eating. This tantrum, however, could also occur because you interrupted them during a preferred activity, such as watching a favorite video. As you learn about your child's mealtime behavior, look not only at the child's behavior, but also at how you and others react to it. In addition, try to identify what was going on at the time the behavior occurred. Once you've identified the eating problems that concern you, set some goals and determine which problems you want to tackle first. You may want to focus on increasing overall caloric intake, increase consumption of solid foods, allow new foods on the plate without gagging or vomiting, etc. Start with one goal or a limited number of goals first. When selecting initial goals, pick ones that are related to an immediate health concern, need to be accomplished to achieve other goals, are a family priority, and you believe will be the easiest to achieve. One primary goal for all children is this: to help the child achieve age-appropriate feeding skills through positive feeding experiences while ensuring swallow safety and adequate nutrition and growth. The next step is developing interventions and solutions. So results and impressions from the clinical examination and any evaluation findings direct the intervention strategies. So again, the primary goal of any intervention is to help a child achieve age-appropriate feeding skills through positive feeding experiences while ensuring swallow safety and adequate nutrition and growth. Therapy may focus on behavioral interventions, oral motor treatments, physical and sensory treatments, adjustments to diet, and the methods of intake, or a combination of these approaches. The family must collaborate with any behavioral interventions to reinforce appropriate responses to food during mealtimes and reduce interfering behaviors to be successful. Oral motor treatment works on improving strength, movement, and coordination of the lips, tongue, jaw, soft palate, and pharynx, and may involve sensory stimulation to these areas, as well as resistance, chewing, or swallowing exercises. Occupational therapy may complement feeding therapy with a speech-language pathologist and help a child develop postural control and self-feeding abilities and decrease adverse responses to tactile stimulation to the hands and mouth. Modifications of the diet may include changing the thickness of liquids, increasing or decreasing the consistency of solids offered, and adding supplemental feedings, such as tube feedings, calorie-dense formulas, or drinks as needed. Changes during oral intake may involve altering position for feedings, altering the bottle, nipple, cup, or straw to reduce or increase the flow rate. An introduction of compensatory maneuvers may improve bolus movement in the mouth and control during swallowing. And an introduction of new tastes and textures can be guided by occupational therapy or speech-language pathology. A combination of these approaches can also be utilized to help address feeding problems. So I know that was a lot of information to take in, but here's a knowledge check question for you. Select all that apply. What is a type of feeding problem? Is it A, food selectivity, B, food refusal, C, talking while eating, or D, difficulty chewing? Again, this is select all that apply. What is a type of feeding problem? The answers are A, B, and D. Food selectivity, food refusal, and difficulty chewing are all feeding problems. A lot of the material that I got from this PowerPoint today was from this book titled Treating Eating Problems of Children with Autism Spectrum Disorders and Developmental Disabilities, Interventions for Professionals and Parents. And this book is by Keith E. Williams. You should check it out on Amazon or in your local library. It has a lot of great information.
So for my portion of the module, I'm going to be going over mental health impacts on the caregiver role, or how maternal mental health may impact your ability to be a caregiver. So first, I would like to discuss relationships within the home. So this could be relationships you have with your partner, with your children, or with your family members. So paternal mental health in either parent can have lasting effects on relationships within the household. So this could include many relationships like I just stated. Mental health concerns can lead to disengagement from the relationship, higher amounts of dissatisfaction in the relationship, lower levels of affection, and high levels of conflict due to unhappiness residing in both couples due to maternal mental health. If the father is more affected by postpartum mental health, it can overall decrease the mother's well-being. So I always like to say that regardless of who is experiencing the mental health, whether it's the mother or the father, that those symptoms end up affecting everybody within the household at some point in some way. So one parent may be diagnosed with a postpartum mental health disorder, but the whole household can experience those symptoms. So next I would like to discuss bonding and how maternal mental health can impact the bonding attachment that a mother has with her baby. So bonding is the attachment a mother has to her baby. This can be feelings of affection, positive feelings, warmth, and smiling or cuddling with the infant. In a study, postpartum mental health disorder was found to be related to bonding difficulties or impairments at 6 to 9 months of age and 12 to 15 months of age in the baby. So this can be the attachment the baby feels with the mother, and it could possibly even impact the child's ability to breastfeed. PTSD may cause avoidant attachment styles in parenting, which may cause greater rejection and anger within the child. So what avoidant attachment is the attachment that is formed between a parent and a baby when the parent is sometimes there and other times not there. And this can be due to a variety of different reasons, but we know that mental health symptoms can be the cause. So I like everyone to think about how you feel when you're having a bad day or an off day, or those days that it feels like your mental health symptoms may be consuming you. It's difficult to continue on with your roles for the day, cleaning the house, taking care of the baby, taking care of your other children, taking care of dinner, worrying about family and your spouse. So through that, you may not be responding to all of your child's cues in a timely manner, or it might be hard to respond to their cues in general. So after time, that can lead to the avoidant attachment, where the baby is just not sure if you'll be there for them or not. So branching off of the previous slide, I would like to discuss attachment. So people diagnosed with a maternal mental health disorder may have difficulty with attachment. Having mood swings or feelings of positive and then negative feelings may create an insecure attachment bond with your baby or your child. Parents may be unresponsive or respond to their child in a negative manner. In order to create a secure attachment with your child, there needs to be consistency. This may mean picking them up when they cry, responding to those hunger cues, affectionate behavior, etc. If a parent is struggling with mental health, an insecure attachment may be found. Now that we've discussed how maternal mental health could impact the role of a caregiver or a parent, I would now like to discuss how maternal mental health can impact their child's development. So being in early intervention, I'm sure a lot of parents are familiar with the word sensory. Each child has different sensory needs. But I was doing research and I found that having maternal mental health symptoms can actually impact your child's sensory needs. So through some different studies, I found some different facts I would like to share. So higher prenatal depression, so depression during pregnancy, made a child more sensory sensitive at 10 months of age. I found that more severe postpartum depression made the child more sensory sensitive at 14 months of age. I also found that more severe prenatal and postpartum anxiety made the child more sensory sensitive at 14 months of age as well. And then in a study, more severe prenatal depression in mothers was associated with sensory needs outside of the majority range in their children at 10, 14, and 18 months of age. And then more severe postpartum depression at 6 months in mothers was associated with their child needing greater sensory needs at 14 months of age. So a trend I found here is if depression and anxiety was experienced during pregnancy, the child had more sensory needs at an earlier age, such as 10 months. If the mother experienced more severe postpartum depression, postpartum anxiety, obviously after pregnancy, it led to their child still needing more sensory needs, but at a later age, such as 14 months of age. So next I would like to discuss behavior and how maternal mental health can impact their child's behavior. So in a study, children with mothers with postpartum depression had high neurotic and antisocial behaviors. So I like to think of the antisocial behavior component of this as thinking about how a child learns a lot through observation. And if you think about how you would feel having postpartum depression, you're not really feeling the most social. So a child is seeing that. So I could relate that antisocial behavior component to just observing how their parent is feeling and how they're acting. A study also shows that mothers with postpartum mood disorders had infants who cried more often and for longer durations than mothers who did not. In a study, postpartum depression in mothers predicts more internalization behaviors in a child, so this could be shyness, depression, and anxiety in their child. So now that we've discussed how maternal mental health can impact a child's sensory needs and behavior, I would like to discuss how maternal mental health could impact the child's cognitive development. So in a study I found infants of mothers who did not have postpartum depression had more success with object concepts at 18 months of age. So object concepts can be thought about as maybe knowing an object is there without being able to see it. So kind of that out of sight, out of mind persona. So an infant is not born with the ability to know that an object is there and permanent, even if they can't see it. So by a couple years of age, a child should be able to know that if, say, a block is covered by a tissue or a paper towel, that block is still there even though they can't see it. If you were to sit an infant down and cover a toy with a blanket, the child would look around the room and not realize that the toy is still located under the blanket. So that's something that children learn throughout the course of their development from a young age. And then another fact I found was boys with mothers who were depressed in their first year postpartum scored lower on the McCarthy scales of children's abilities compared to children whose mothers did not have postpartum depression. And the McCarthy scales of children's abilities is a psychological assessment for young children, and it measures different areas of cognitive ability, and those could be verbal ability, perceptual performance, quantitative, general cognitive abilities, memory, and different motor skills. So we've now discussed how maternal mental health can impact sensory needs, behavior, cognitive development, and now I would like to discuss how sleep can be affected by maternal mental health in children. So children with sleep problems were more likely to have a mother who scored higher on the depression scale than those who did not have sleep problems. So the higher the score on the depression scale, the more depressed the mother is. Depression in the third trimester of pregnancy shows infant sleep anxiety and more daytime sleepiness at 6 months of age. And then depression 2 weeks postpartum in the mother shows more overall sleep difficulties in their child at 6 months of age. So now that we went over some specific areas, I would like to just discuss some general difficulties babies may have with the effect of maternal mental health. So babies might have difficulty interacting with their parents. This may be due to the different anxious or avoidant attachment styles that I discussed earlier. They may be more withdrawn or passive towards their parents, and they can also just have general difficulties in reaching developmental milestones, so they may qualify as being developmentally delayed. So how does maternal mental health affect toddlers? So they can end up being more aggressive. They may be less independent. They may have less social interaction with their family members or outside family members, and they can be less receptive to different types of discipline. So how can maternal mental health affect children once they reach school age? So having maternal mental health symptoms or disorder may have put your child at risk for ADHD. They could have a higher risk for anxiety and depression. They may be more behavioral, and we've seen that trend through babies and toddlers, being more behavioral, less receptive to discipline. And they may also just have general difficulties in school, and this may be due to being put at a disadvantage in their younger years, reaching those developmental milestones. So now that we've discussed specific areas in your child's development that might be impacted by maternal mental health symptoms or diagnosis, I would like to just discuss the overall effect that these symptoms can have on children. So they can overall have more global developmental delays. So that can be in walking, crawling, using their fine motor skills such as stringing or stacking. They may have a more negative affect, so they might have difficulty expressing emotions. They can also have that low level of like social interaction that I discussed earlier. They might have language delays, and this can be due to having less exposure to other people. There's different reasons why this might happen. They could have less sustained attention during tasks. So this could play into having that higher risk for ADHD once they reach school age. They might have more tantrum-like behavior. So again, we're seeing a trend with a lot of possible behavioral issues that a child can develop due to a parent having maternal mental health. And then they could also be at high risk for anxiety and depression, like I said before. And they might have a higher risk for ADHD, which could maybe lead to having a higher activity level in general. So what can we do about it? So first off, we want to try to create a positive environment. So a child's success in reaching these developmental milestones really comes from the environment that they're in. So we want a supportive and positive environment. So just being very conscious about how you act, how you react, and the relationships that your child is exposed to in their home. Next, we want to use positive reinforcement for your child, so really praising them for any positive behavior. So in therapy, I know in pediatrics we use a lot of praise. So if they even interact with maybe a food that they haven't interacted with before, or showing us a new skill, really like clapping, saying yay, making it really positive for the child. Next, we want to take time to just think before we react. So if we're having a bad day, it's very easy to be super irritable and agitated, and a quick reaction might come off more harsh and negative than we would have liked. So just taking a step back when you're frustrated, taking a break before coming back and reacting to that stimulus. Next, we want to have social support. So I talk about all the time how peer support is super important. So creating just a little group of people that you trust can be very helpful, just to talk about feelings and tell stories and maybe share experiences. So I like to always say to have this group set. Think about preparation and who you want to be on your team during this time in your life. Next, talk to a therapist. So, of course, talking to friends is great, but we want to talk to a professional who can really help sort through your situation and possibly refer you to outside resources if needed. And we also want to practice self-care. So, you may have heard that when a mom has a child, it's hard for her to separate who she was before and who she is besides being a mother. So I recommend trying to connect with that part of yourself again, listing out the things that you like to do, things you previously liked to do before having a child or even while having a child, just different activities that make you feel good, whether that's taking a bath or going for a run, going to the gym, getting your nails done, just practicing different things that make you relax and feel overall just better and lighter in that situation. So now that we've discussed how maternal mental health can impact parenting, caregiving, and even a child's development, I would like to do a little knowledge check. So what aspects of child development can be affected by maternal mental health? Is it A, behavior, B, cognitive development, C, sensory needs, or D, all of the above? The answer is D, all of the above. Sensory, cognitive development, and behavior can all be impacted by a parent having a maternal mental health diagnosis or symptoms.